This patient exhibits classic features of post-infectious IBS. Post-infectious IBS occurs in up to a third of patients who will seek treatment for IBS. In these cases, patients associate the onset of their symptoms with an acute bacterial, viral, or parasitic GI infection. It's important to identify these patients since they're likely to follow a different clinical course than the typical patient with IBS. Unlike garden variety IBS, remember that 2/3 of post-infectious IBS patients will experience spontaneous symptom resolution within a period of 5 to 6 years. So the traditional message that we give IBS patients, and I might add, not a very hopeful message, that we really don't know why they have IBS, and that it tends to be a chronic, lifelong condition, really doesn't hold for patients that have post-infectious IBS. For these patients, a much more hopeful message can be relayed to the patient. You can tell them that their illness is clearly related to changes in function and sensation of the GI tract that occurred as a consequence of their acute GI illness, and that most patients get better over time. So what we need to do in the short term is find solutions for their ongoing symptoms while their body heals itself. This patient has fairly mild IBS symptoms, and as such, providers should focus on establishing a confident diagnosis, doing exactly what we just said, explaining to the patient that the patient has post-infectious IBS, educating them on what that means, both in terms of why they have the symptoms they do and what to expect going forward. That hopeful natural history, oftentimes in and of itself, is therapeutic for the patient. I can't tell you how many times patients have come in. We've taken a careful history, identified that they have post-infectious IBS. I've explained that to them, and they've actually become tearful because they feel that they finally have an explanation for why they have this problem. And they're hopeful because most of the time they're going to get better on their own. It's also important to talk about the role of diet and lifestyle in all patients with IBS, not just patients with post-infectious IBS, but all patients with IBS. The low FODMAP diet is an evidence-based dietary intervention for patients with IBS. Gluten-free diets have also been utilized, less evidence-based, but some patients certainly get benefit from this strategy. Remember that if you use a low FODMAP diet for IBS, a 2 to 6 week exclusion period is more than adequate. They should not be placed on long periods of a highly restrictive diet. If a patient doesn't respond, you can abandon the diet strategy and move on to something else. If the patient responds, remember that the low FODMAP diet is a 3-phase process that includes not only exclusion, but also reintroduction of foods that contain individual FODMAPs to identify a patient's individual food sensitivities, and then using that information to fashion a more liberal diet that the patient can take forward. So thinking about ESP, excluding FODMAPs to determine whether a person is FODMAP sensitive, determining their sensitivities, and then personalizing a diet for them to take forward over the long term. In addition, over-the-counter medications can be very helpful for patients with mild and frequent symptoms. So, for example, an anti-diarrheal, either to treat symptoms acutely or perhaps even more helpful in many patients, using prophylactically to prevent symptoms where one anticipates that they might have problems. Like, for example, if they were going to give an important business presentation or travel, using an anti-diarrheal to prevent them from having problems with diarrhea can be life-changing. Also, using supplements like, for example, peppermint oil can be very helpful for abdominal pain and bloating. And some of the more recently released enteric-coated formulations can mitigate the risk of developing heartburn as a consequence of using peppermint oil. And then finally, probiotics can be very helpful for gas and bloating. If you go to the prescription medication space, drugs like tricyclic antidepressants can be very helpful, particularly for pain. Rifaximin, the non-absorbable antibiotic, which is FDA approved for IBS-D, can be very helpful for some of these patients. Drugs like 5-HT3 receptor antagonists, so drugs like ondansetron or what you're probably more familiar with as Zofran, or allosetron, can also be very, very helpful. Finally, a recent entry into the IBSD treatment armamentarium is eluxadiline or Viberzi, which can be very useful in terms of helping patients with their IBSD symptoms. Remember that if you're going to use eluxadiline, you shouldn't use this drug in individuals who have undergone a previous cholecystectomy or consume more than 3 alcoholic beverages per day.